Hello, this is Matt Hartman from Pittsburgh, PA. This is the first intro to radiology imaging for the building blocks. I'm joined by Davin Evanson from Drexel University. And all of these lectures can be found on the ACR building block site. This lecture is actually adapted from one of Dr. Webb's intro lectures from UCSF. So credit to her, some outstanding learning material there. I threw in a couple of Hartman pearls, which I think you will enjoy. And if you want to go back and get the whole presentation and other presentations, go to the building block site. Here's the QR code. It's free for medical students. And we have a ton of great material: anatomy, intro to imaging, senior modules for all the different clerkships, then the RadPath channel. And we have YouTube videos. I'm in the process of making YouTube videos for a lot of these things. Again, the YouTube videos are sort of intros to sort of pique your interest, sort of prime you for these topics, and then go back, download it, take your time going through the material. So here's the RadPath channel. We have like 15 lectures on there. And we also have Anki flashcards for the radiology material for RadPath and the AMSR learning objectives for the regular course. If you like Anki Deck, you can get the directions on how to download those. So I'm a body imager. I love RadPath. And this is meant for the future clinician. I know most of you probably are not going into radiology, but you'll be using radiology each day in your careers. So sort of a radiology boot camp. Get everyone ready. And a lot of this will be non-interpretive skills. I'm not teaching you how to read a chest x-ray, but want to go over some of the basics for radiology. And again, this is one of the foundations. We need to know some of this basic information before we can start interpreting the studies. And there's about 100 slides. My goal is to have this be between 20 and 30 minutes. So I'm going to be going a little bit faster. I might skip some of the material, but you can always pause. You can always go back. And I feel most of you are going to be watching me at double speed anyway. So here we go. Here are the learning objectives. Basically, just get some basics of radiology, x-rays, CT, the different modalities. So whenever I have new med students, high school students with me, I always start with this question, and most people cannot answer this correctly. What are x-rays? So I'll give you a couple of seconds to think about what an x-ray is. And we have to know some basic physics. This is our friend, the electromagnetic spectrum, different types of waves which have different frequencies and wavelength. Remember, those are inversely proportional. So here we are increasing the frequency, and we will see radio waves, microwaves, infrared, our color spectrum, Roy G. Biv, ultraviolet, and then X-rays and gamma rays. This is what we're going to use in radiology primarily. Well, we'll also use sound waves for ultrasound, but we'll come back to that. But we are going to focus on X-rays. And I promise this is the only physics-y type of slide. Planck's equation, E equals hv, Planck's constant times frequency. So if you have a high frequency, it's directly proportional to energy. So high frequency equals high energy. Again, there are X-rays and gamma rays. Then also notice that X-rays are a spectrum. Not all X-rays are created equal. So if we're going to do a radiology study on a baby, we will use the lower energy X-rays versus if we're trying to penetrate a bariatric patient, we have to ramp up the voltage, use our higher energy X-rays to penetrate the patient. So that's some basics from physics. Hopefully everyone is comfortable with that. So X-rays have been around since the Big Bang, but they were discovered in 1895 by William Röntgen. And for this, he got the Nobel Prize in Physics. Basically, he was just fooling around with some high energy material, put a photographic plate in front, and this is the first time humans got to see inside the human body. This is actually his wife's hand, and you can see the metal there, it's sort of brown. And then, refined his technique, and this is one of his friends' hands, always using the hand as a good model. And again, you can see the ring there. We'll learn that the X-rays will be absorbed by metal and bone, and depending on how we have it, the parameter set will usually be radiopaque. In this case, they're black, but in most instances, we invert it, and things that are radiopaque will be white. So, next question, what do radiologists do? I get this asked this a lot. And the best answer is that we make use of waves to aid in the diagnosis and treatment of patients. And we'll see different types of waves: sound waves for ultrasound, x-rays for radiography, CT, and then we'll talk about special waves that we use with MRI. So these are all the different types of exams we can do in the radiology department. And we'll start with the x-rays. So you have your x-ray generator. It goes to the patient and it is directed at the cassette. In the old day, when I was a resident, it was actually film. It would precipitate a silver reaction. Now everything's digital, but the same sort of principle. If the x-rays make it through, it will turn it dark. If they get absorbed, it will stay white. So that's why the lungs are black and the bones are white. There's a shoulder radiograph, abdominal radiograph. So the degree of whiteness seen in an x-ray is an effect of three different things. So basic physics here: the density, the thickness, and the superimposition of different structures. So density, so this is metal. It all comes back to chemistry in the periodic table. A heavy element, tightly packed nucleus, will absorb the x-rays. None of the x-rays actually make it to the detector, and it will keep it white, radiopaque. X-rays, if they go through air, no problem, like the lungs, turn it black. And you can imagine somewhere in between gray, so black, white, shades of gray. There's air, fat, soft tissue, and then bone/metal, black, white, shades of gray. Here is an abdominal radiograph. What are these things, do you think? Those look like bullets to me. Radiopaque metal. They absorb the x-rays. So this is pretty cool thickness. So here we're looking at some barium. Actually water from the side. You know, we have like twice as much water there. On the side, they look the same density. But when you look from the top, x-rays are going through more stuff, will be more radiopaque. Overlapping structures can make things more dense. Here you got crossing ribs. You get different shadows with spinal lines, muscles. You can see here at the costophrenic sulcus, there's no breast shadow, so there's less stuff, and it will be darker. So x-rays are like taking a picture, portable. So for some of our really sick patients, you can take a portable radiograph. Here's an ICU patient. Probably one of the most commonly ordered studies in the hospital is just a portable chest x-ray. The drawbacks. Unfortunately, they are not the most sensitive or specific. You can miss disease very easily. And for that, we often need to put everything together with the clinical history. So here's an example. The lung is too white. What's going on? Well, all I can say is there's something in the lung that's absorbing the x-rays. That something could be blood, water, cells, or pus. This is from Dr. Furman, who taught me at the University of Pittsburgh. Anytime something in the body is too bright, you have pathology, be thinking of this differential: blood, water, cells, pus. That might have been a trauma patient. It might be a pulmonary edema patient. Maybe that was a cancer. Maybe that's a bad pneumonia. Blood, water, cells, or pus. Okay, orientation. Important to know how the film was taken and what we're looking at. So we're looking at the patient head on. So this is the patient's right. This is their left. So here's a shoulder radiograph. It's important to make sure that it was labeled correctly. So this is why we put it on there, so we know that we are imaging the right, I should say the correct part. In this example, the right shoulder. Then, how was the film taken? The view describes the position of the patient relative to the X-ray beam. So when we do a regular, you do a chest radiograph, it can be done one of two ways. This is a PA radiograph, which we prefer if the patient can stand. The X-ray beam is going posterior to anterior. Their chest is pressed against the cassette. So a PA radiograph. as opposed to AP radiograph. This would be your sick patients in the ICU, too sick to stand, and you just bring the X-ray machine right on top of them. It's going anterior to posterior. Why does this matter? Well, issues of magnification. Inherently, the X-ray image, a radiograph image, will be magnified. And realize if you have the further away it is from the cassette, the more magnified it will be. Why is this important? Well, the heart will appear larger on the AP film. The heart is an anterior structure. And when you do the PA radiograph, the heart is right against the cassette, so there's less magnification, whereas with the AP, it's further away, so you have inherent magnification. So anytime we can do a PA radiograph, that's one of the reasons we like to do it. So again, this is the AP view. Again, the heart is here. Anterior structure has to go. It will be magnified as opposed to a PA view. Okay, here's some other structures. Lateral view. So again, X-ray beams are going this way in the detector, and you get a nice lateral radiograph there. We see the spine, posterior, anterior, lateral view of the knee, again, anterior, posterior, and things we're looking for. We'll talk about how to read an abdominal radiograph later, but stones, bones, mass and gas, you'll hear me talk about that. You can see different structures. It's going to sort of go through these. You can pause this. Fluoroscopy is like taking a movie. And the cool thing is this table can move any which direction. It's like taking the movie here, in the old time, making the pictures move. It's literally taking a bunch of quick little X-ray images in succession, and it makes it into a movie. We have to have the patient drink contrast. I encourage everyone to watch the contrast video because we want the GI lumen to be opacified with something, and we will often use barium. You can look on the periodic table, it's pretty dense, so that's why it will appear as white or radiopaque, and sometimes we'll use water-soluble iodine, which also has a high atomic number. So here's a nice example of a patient drinking the barium. Oops. See the contrast going through the esophagus, the pharynx, into the cervical esophagus and down. Maybe a little bit delayed, but it's going down the right tube, which is good. This is an abnormal swallow, and there's some contrast loop in there, and that big glob just went down the trachea. This is a patient who's not safe to eat on his or her own. Patient is probably going to need a feeding tube, or else they're just going to keep getting aspiration pneumonia. And you might say, why was the barium bright on this one and dark here? Well, we can inherently invert the images. Sometimes it's helpful to have the contrast darker. Sometimes we like it to be white, but that's something we can manipulate as the radiologist. Now, wouldn't it be nice if we could quantitate how black, how white, how gray something is? This is great to see inside the human body, but we want to see, it would be great if we could quantitate it. And this is where Sir Hounsfield came in. He had the idea, and he came up with the first CT scan. And for that, he got the first Nobel Prize in 1979. There's actually a really interesting story about how the Beatles and their record label, the profits for that went into helping to fund the first CT scanner. So what is a CT scanner? Well, it's basically X-ray detectors going around 360 degrees as the patient goes through the tube. And there's some fancy physics here, which you can do on your own, read more about. But we have the X-ray detectors in white all the way around, and the X-ray beam going around being detected by these different detectors to put all the information together, and basically using some pretty advanced calculus to figure out what the density at each point or voxel is in the human body. And you can get some very detailed information, stuff we could not get with the just regular radiographs. Again, the positioning is going to be very important. Again, here, this is the belly, anterior, posterior. Again, the patient's right, the patient's left. This is how we're looking at the body as they go through the scanner. And I promised we were going to quantitate how dense these X-rays were. And since Hounsfield discovered the CT scanner, we said, hey, let's name the scale after him. So this is a measure of CT density. It goes from -1,000 for air, that will be the darkest, to +1,000 for bone or metal. We will set water being 0. That will be about -100. Bone will be 30. And let's see an example here. Here is the chest. There's the trachea, air, -1,000. The lung, -500. We're going to have some fat, about -100 there. That's the sub-Q fat. We're going to have blood in the blood vessel. Realize it depends if there's contrast or not, about 30. We have our muscles, about same as blood, about 30. And then our bone/metal, just think of that as about 1,000. So that is fantastic. We can quantitate how black, how white, how gray things are in the human body. And we can use this. This will seem like magic the first time you ever see it, but after the patient's scanned, we can change the grayscale. If we want our grays in the centered in the negative numbers, that's called lung windowing, and there you can see the lung detail. If you want it centered on 0 for water, we can't. You'll get great detail for the soft tissue structures, but the lungs seem like they disappeared. The information's still there, but the computer algorithm is just saying anything less than -100 just be completely black. And then if you want to see the bone cortex well, we put on bone windows. We're going to be centered on a higher number where we can get some good bony detail. So this is called CT windowing. We are just changing the grayscale. So orientation is very important when we're scanning the patient. And we're going to go through the human body here, through the head, through the neck. Notice the bones are going to be bright, just like on our x-rays. They're getting absorbed. Here we're in the belly. Here we're in the lower extremity. I sometimes call the CT the truth machine. That's much more sensitive and specific than a regular radiograph. You can get some cool 3D reformats. So this is the coronal plane, looking at the patient front on. This is the sagittal plane from the side. And you can get some really cool multiplanar reformat. These are the coronary arteries, and we're looking at the right coronary artery there, a very tight stenosis. That tells the cardiologist where to go, dilate that, put a stent in, fix the patient. So some really cool images. So this is an example of a plain film. You're like, hey, the patient has pain there. Is that a vascular groove or is that a fracture? I'm not sure. Let's do a CT scan, and clearly we can see the fracture line. In fact, it looks a little bit comminuted, several fracture lines there. So this is of the posterior acetabulum. Okay, let's switch gears, go to MRI. And basically the patient is going through a big magnet. Lots of physics here. It's going to be 1.5 or 3 Tesla usually. And what we're trying to do is to use the hydrogen spin. We want all the hydrogens either going up or down, and realize the hydrogens, whether it's with water, fat, protein, tumor, whatever, will have a different local environment. And we can shoot radio waves into the patient, and whether it's hitting a hydrogen on water, hydrogen on fat, hydrogen in the tumor, and protein will act differently and will send a different signal back. And that is what's going to give us great contrast resolution. We'll see some examples of that here in the brain. So again, we're using the hydrogen spin in different structures. And one of the things I want you to note, we'll focus on this, is that with MRI, the bones are going to be dark or hypo-intense. This is actually fat right here. That's going to be bright or hyper-intense. This is I'm going to have it, I think on one of the next slides, CT versus MRI. It'll make even more sense. You'll hear things like T1 or T2. I'll introduce it right here. T2H2O. Water will be hyper-intense on T2 images. This is a T2 image. Here's the image I was talking about. Here is a CT. Note the bones are bright. The bones are bright. This is on the bone window. We talked about the different leveling. On MRI, this sort of, the bones are definitely dark here, hypointense. CSF is bright. That's our T2. And here you just have to realize that's the bone. So it's dark. It's MRI. The vents are dark. This will work 90% of the time. This is T1, and watch the neuro video. There's a couple extra tricks we can do. So the patient goes in, takes much longer than CT. Patient has to stand still, might get claustrophobic. It's very loud. We'll put headphones on the patient, let them listen to whatever music they want to, and takes a lot longer, more expensive. Some definite safety issues. You can watch I refer you to the MR safety module. We're dealing with a strong magnet. Any metal object that gets too close can act as a projectile. So that's why it's very important screening protocols. And despite that, this was the janitor cleaning the room at night, didn't get the memo. The sweeper got a little bit too close, got zapped into the MR scanner. This was a patient in a metal cart. Again, the safety protocol was not followed. The cart got yanked into the MR scanner. This is a big deal. They have to quench the MR scanner, basically let out all the liquid helium and reset the MR scanner. And you can imagine also dangerous if a patient were in there. Several fatalities have been related to metal objects becoming projectiles and hitting patients. So MR, though, not to scare you, is fantastic for lots of things. MSK, spine, neuro. Let's switch gears and talk about ultrasound using sound waves to look inside the human body. Think of OB/GYN. We have some great modules on the building blocks for our future GYN docs and clerkships. There's a little baby inside. There's no radiation. Same with MRI. So anytime you have a pregnant patient, we love doing ultrasound or MRI. Lots of physics here. I'm going to go a little bit fast through this. Again, you can pause on this, but basically using the sound wave going through the patient, hitting different structures will determine if it's going to be bright, hyperechoic, or dark, anechoic, or somewhere in between. So here is an ultrasound of the gallbladder. Most of the liquid is going to be anechoic. There's something bright in there. That might be a polyp or a stone. So things that are liquid will be black or anechoic. So fluid, bile in the gallbladder. So let's use this as a second to review. We have seen water in different modalities. So on CT, 0 Hounsfield units. On MRI, water is T2 hyperintense, just remember the CSF, and T1 hypointense. And on ultrasound, anechoic. Things that are bright or echogenic on ultrasound, stones/bones, fat, and gas. And if you remember, on CT, these were two of the darkest things. This was negative 100 Hounsfield units. Air was negative 1,000 Hounsfield units. It just has to do with the interface and the properties of sound waves going through those substances. So our ultimate enemy in ultrasound is a patient with a lot of fat and gas. So oftentimes we're asked to do ultrasounds of the belly on post-op patients, lots of gas, bariatric patients, and you as ordering physicians just have to realize, because of physics, our sound waves cannot penetrate to get to the liver or the kidneys easily, and a lot of times we have to say the study was non-diagnostic. So just realize if you're ordering, when you're ordering those studies, we are at the mercy of the physics for how well the sound wave can do. Now, a couple tricks we can do using different types of probes, but ultimately we're at the mercy of physics. Let's switch gears to nuclear medicine. This is really cool. We remember our electromagnetic spectrum. We're going to be really focusing now on those gamma rays. And what we are doing is we're injecting the patient with a radio tracer. A tracer will go through the body, whether it's a bone scan, bleeding scan, HIDA scan for the gallbladder. It goes to our area of interest, and it's tagged with usually technetium, which is giving off those gamma particles, and then lights up for us. The camera picks it up, and you can say, hey, there is lots of activity there in the hilar region. They're in the stomach. And sometimes that's a normal finding, sometimes it's an abnormal finding. That's one of the challenges of nuclear medicine. But I really want to focus on PET CT. This is something that came out when I was a resident. PET CT fuses the anatomic information provided by CT with the metabolic activity provided by PET. PET is using positrons. This is some pretty advanced physics, but just think of it as a radioactive particle that's being emitted that our detector can pick up. So if we only had a CT, you'd say, hey, there's an abnormality there. Maybe it's atelectasis, maybe it's a tumor. I'm not sure. But we put the PET, and basically what you're doing is you're injecting them with FDG, fluorodeoxyglucose. This is radioactive sugar, and it looks just like glucose, but you take deoxyglucose, you take one of those oxygens off, and you put a radioactive fluorine on there, F18. Look at the periodic table. F18 is very similar to OH, so it's a pretty even substitute. And this radioactive sugar can go through the first couple steps of glycolysis before one of the enzymes wises up, does not recognize that radioactive sugar, and it stops mid-glycolysis. But in the meantime, it has been taken up by those hungry cells and lighting up, giving off those positrons. And we will then fuse the two images together and get a real pretty image here of a invading carcinoma very close to the carina. And one of the big advantages is using this to look for unexpected sites of metastases. And realize this is going to totally change the patient's prognosis if you diagnose metastases. So I'll give you this unknown case. This is a patient with rectal cancer, and we can see there is a lot of activity there in the rectum. So we already knew that from the colonoscopy, that there's a big rectal cancer, but they want to know, are there Mets or not? And I'll give you guys a couple seconds. Do you see any unexpected sites? Well, this is the bladder. Unfortunately, the bladder is going to excrete some of this FDG. That's actually a normal finding. But what's this spot right here in the liver? That should not be there. This is a liver metastasis. So we've just upstaged this patient from a local rectal cancer to a metastatic rectal cancer. We'll end with one case. Here's a patient with a subcarinal mass. This is non-contrast CT. We do the PET. And I should mention, we can actually quantitate how much activity there is, something called the standard uptake value. Here it's 20. A normal value is 2.5. Anything less than 2.5, you say, don't worry about that. And you realize that there are a couple of false negatives, but that's a good rule of thumb. So this is definitely very FDG avid. We're worried about malignancy. Oh man, but the fused image, very suspicious. This has to be cancer, right? Slam dunk, this is cancer. Well, when you do RadPath with us, you learn tissue's the issue. We did a biopsy, and instead of cancer cells, we saw non-caseating granulomas, histoplasma. So not everything that lights up is cancer. You just imagine these hungry histoplasma granulomas taking up the radioactive sugar will look very similar to a cancer. So I just wanted to throw one false positive out there for you. So this was a whirlwind. We finished in just over 28 minutes, but I think this was a good introduction for you guys. We really focused on basic x-rays. We talked about CT scans, and then we touched on ultrasound, MRI, and nuclear medicine. So I encourage you to download the entire presentation, go through it again on your own time, and then watch the other videos and get excited for radiology.